I want to thank the Society and the chairpersons of the session for inviting me to be part of this very important session you put together. I have no financial conflicts of interest regarding this presentation. Since I'm here in the UK, I will start with a quote from George Bernard Shaw: "Beware of false knowledge, it's more dangerous than ignorance." And in the next few minutes, I will do my best to convey relevant evidence-based knowledge while also trying to avoid emphasizing ignorance. Let's first quantify the importance of this topic. The World Health Organization reports show that there are over 2.5 million new cases of lung cancer worldwide each year. That's 1 in 8 of every cancer that's diagnosed, and it's the most commonly diagnosed cancer on Earth. Furthermore, lung cancer accounts for 1.8 million deaths each year. That's over 1 in every 6 cases of cancer deaths. Again, the leading cause of cancer death in the world. Here in the UK, the data is just as stark. Cancer Research UK reports that there are nearly 50,000 new diagnoses each year. That's over 130 cases, new cases each day. Lung cancer is also the #1 cancer killer in the UK, with almost 100 deaths per day here in the UK. So it's clearly an important topic we have to manage in our surgical responsibilities as thoracic surgeons. Having established the importance of the burden of lung cancer, I think, for the purposes of today's discussion, that it's important to briefly review some of the relevant events in the history and scientific evolution of lung resections for lung cancer. In other words, we have to see where the pendulum has been in order to evaluate its trajectory and whether it has swung too far. And since we're here in Wales, I think it's worthy to remind us that it was only just over 100 years ago that a 33-year-old Welshman from Cardiff, Hugh Morrison Davis, performed the first lobectomy by hilar dissection on a 44-year-old man with a right lower lobe lung cancer. That's the starting point for our discussion today. In this actual case, the diagnosis of a lower lobe tumor was established at an early stage by the nascent technology at the time of chest radiography introduced by Morrison Davies, against the resistance of his local radiologists, who considered radiology useless for the diagnosis of chest diseases. That forced Morrison Davis to actually install his own X-ray apparatus in a basement room of the hospital. He approached the tumor through the 6th interspace and performed individual hilar dissection and ligation, but unfortunately his patient did die of an empyema on postoperative day 8. But the bronchial closure at autopsy was found to be intact. These were the early days. Now, we're all also familiar with Everts Graham and his pioneering work from my old training grounds at Washington University in St. Louis. This is Everts Graham with his first patient treated for lung cancer by pneumonectomy, a local St. Louis dentist, James Lee Gilmore. He would go on to outlive his surgeon. Which brings us to Bob Ginsberg, at the time from the University of Toronto, Canada, my surgical alma mater. His work with the Lung Cancer Study Group produced the randomized surgical trial we all know well of lobectomy versus what he termed at the time limited resection for T1N0 lesions. This trial was a massive undertaking for any time, but especially in the late 20th century before the internet, Zoom meetings, and electronic medical records. The study established lobectomy as the gold standard for pulmonary resections for lung cancer for a generation. The frequency of local recurrence was 3 times as high with sublobar resection as with lobectomy, and lung cancer-related mortality was 50% higher with sublobar resection. These results established lobectomy as that gold standard. Following this, modern lung cancer screening came of age, with advances in technology, staging, and our basic understanding of lung cancer. We've become able to detect lung cancers at a much smaller size, earlier stage, and seemingly better prognosis, such that intelligently structured screening programs could actually reduce lung cancer mortality. The National Lung Cancer Screening Trial, a randomized study of over 53,000 patients at centers in North America, demonstrated a 20.3% relative risk reduction in lung cancer mortality in the low-dose CT arm, and a 6.7% relative risk reduction in all-cause mortality, similar results obviously were confirmed on this side of the Atlantic as well. The rush to the CT scan was forecasted, but generally has not been encountered. We've nevertheless all seen more of these, and we've seen these this morning when we talked about robotics, and we'll see them all throughout this meeting. The small, asymptomatic ground glass opacity with a central solid component indicative of early-stage lung cancer. With these early-stage lung cancers being discovered more readily and more frequently, there arose an initial debate regarding the role of stereotactic radiation treatment versus, at that time still, conventional surgical lung resections. This was the archetypical error of bringing a knife or a scalpel to a gunfight. As Shaw said, progress is impossible without change, and those who cannot change their minds cannot change anything. The widespread reappearance of radiation treatments for lung cancer at that time reminds me of an earlier similar landmark event. October 4th, 1957, the populations across the globe arose to a repetitive beeping that signaled the start of the space age. Sputnik 1, the first Earth-orbiting artificial satellite, was launched into an elliptical, low Earth orbit by the Soviet Union, and it was greeted with both fear and awe. The news stunned the world. This is from a previously classified presidential briefing notes of the then U.S. President Dwight D. Eisenhower from October the 8th, 4 days later. The Soviet launching had been highly successful. Now, many would have slunk away and cowered at the news of success by their rival. Not Eisenhower, not Ike. He saw this pivotal moment as a clear opportunity. The United States must meet this challenge with resourcefulness and vigor. We must galvanize our efforts in the sciences and provide the resources to our best and brightest. He quickly drew up the National Aeronautic and Space Act that created NASA. And by executive order, he increased the funding of the National Science Foundation by 400%. In less than 2 years, that initiative brought us the Mercury Project and these 7 pioneers known to us collectively as the Mercury 7. Well, in thoracic surgery, SBRT could be seen as our Sputnik moment, and it spurred innovation too and ingenuity within our specialty. We too have what we could call our Mercury 7 or more. And for the purposes of balance, I propose you these 7 pioneers in minimally invasive lung cancer resections to answer the challenge of SBRT and, more importantly, to answer the needs of our patient. Joining me here at the podium today, we have another pioneer, Agathe Seguin-Givelet, who, after me, will show us all ways to go further and beyond with our minimally invasive surgical resections. Which brings me to segmentectomies. This is from our Mayo Clinic presentation from now over almost 12 years ago. In it, we showed that in appropriately selected small early-stage lung cancers, we could achieve similar overall survival with anatomic segmentectomy as with lobectomy. We also confirmed that local recurrence, however, was less than with lobectomy as compared with segmentectomy. We also showed that the difference in pulmonary function as measured with FEV1, and we can debate whether that's the right measure, was very small and likely clinically insignificant. While our Mayo Clinic study was a single-center study, Nasser El-Torki led a multi-institutional randomized prospective trial of over 700 patients. Many of you here were lucky enough to hear him present on this study at this very meeting last year in Birmingham. I'll just summarize the conclusions here. Overall survival was the same between lobectomy and segmentectomy. Local recurrence was less with lobectomy. Distant and local recurrence was similar between wedge and segmentectomy, and furthermore, they found no real difference in pulmonary function changes between wedge resections and segmentectomies. Also of relevance in this discussion are the data uncovered by the large multi-center Japanese prospective randomized trial comparing lobectomy to segmentectomy and presented by its surgical principal investigator, Professor Hisao Asamura. Here, the a priori endpoints were survival after segmentectomy is not inferior to lobectomy, and postoperative pulmonary function after segmentectomy is significantly better than after lobectomy. The conclusions that Professor Asamura and his group found was that overall survival after segmentectomy is not superior to lobectomy and that the lung cancer mortality was the same in each group. They found that the postoperative pulmonary function after segmentectomy was only 3% better than after lobectomy, which is likely not clinically significant. And lastly, that segmentectomy was associated with more frequent local recurrence, longer operative times, and more prolonged air leaks. So where does this leave us? It might be confusing at first glance, even at second glance. I'm going to now humbly give you my own analysis and how I've been trying to work all of this out. And hopefully you won't see that as blasphemy, but maybe that wouldn't be such a bad thing. When in doubt, return to foundational principles. And in the field of thoracic oncology, I return to the principles that Bob Ginsberg taught us all repeatedly. First, if you don't look at lymph nodes, then every cancer is a stage 1 cancer. So the importance of lymph nodes becomes paramount. Next, when you realize that R0 resection is a prerequisite for a good long-term survival, then the characteristics of the tumor, its size, and particularly its location, put in the context of the patient, the individual patient's physiologic capacity, become important factors in using surgical judgment to choose the appropriate surgical approach. Anatomy becomes destiny. When a small tumor presents itself centrally within the true confines of a pulmonary segment, segmentectomy then becomes a real and very useful option. Where the pendulum may have swung too far is in trying to force a segmentectomy onto every situation, whether it makes sense or not. Just as in golf, where you wouldn't likely be a very competitive or good golfer with only one club in your bag, in thoracic surgery, we limit ourselves if we look at our world of lung cancer treatment only through the lens of segmentectomy or any single operative approach. A lesion straddling an intersegmental plane, a small peripheral lesion, issues related to prior resections, as well as many other particularities or peculiarities argue for an individualized approach. Again, as Ginsberg would repeat, selection before resection. The more options we have, just like the more clubs we have in our bag, the more adaptable we will be to meet our individual patients' needs depending on their individual situation. A segmentectomy, a wedge resection, a lobectomy, a sleeve resection, an en bloc chest wall resection, or even, hopefully rarely, a pneumonectomy, may all at each particular time be appropriate, and our patients will be better off if we not only have the technical skills necessary for each of these options, but also the good judgment to know when one option is better than another for your individual patient. Never force a patient's situation to conform to a specific operation. Use the best approach to fit the particular situation. Or as they say in golf, play it as it lies. And bring all your clubs to the operating room. Thank you for your attention, and I look forward to your subsequent questions. Thanks.